Sure. Hi, everyone, and welcome to our webinar. We have the pleasure of having Dr. Anne-Marie Reed of Leeds Institute of Medical Education to present on contemporary approaches to curriculum development and quality assurance. So welcome, and please begin.
Thank you. Thank you very much for your introduction. So I'm Anne-Marie Reed and I work in the University of Leeds, and I have a lot of experience of curriculum development both in the UK and internationally. And I'll tell you a little bit more about that as we go through the presentation. Could I have the next slide, please? So during this presentation, I'm going to help us just revisit the curriculum and its components, to think about the curriculum in its widest sense. And I'm also going to get you to think about how the curriculum should address healthcare needs in whichever context that is. And then I'm going to go on to talk about how we might judge the effectiveness of the curriculum. And in particular, I'm going to make some reference to the World Federation for Medical Education standards for medical education. So I know a number of people who are joining the webinar will have quite considerable experience as well, but I'm hoping to extend some of your thinking and to help give you some food for thought, whether this is an area quite new to you or whether you're someone quite experienced. Could I have the next one, please? So for me, when we start to think about the curriculum, I think each of us may have a slightly different understanding of what we mean by curriculum. For many people, they see it as the blueprint, which gives a diagrammatic structure of perhaps the timetable and the content. And that's important, but there's other aspects to it too. And I think one of the things that we have to be very clear about is, what do we want to achieve through the curriculum? What are the aims of it? And vital to this, when we're thinking about medical students and health professional students, we need to think very carefully, what do graduates need to know and understand? What do they need to be able to do, and how should they do it? And I think vital to that is the fact that the curriculum is not static. It cannot be static because the training of doctors needs to move on with the time. As our understanding of medicine, as technology moves on, we need to keep revisiting what graduates need to know and understand. And that's the purpose really of curriculum development and thinking of curriculum quality assurance. For me, there's also a very important question: who should decide what's needed? Is it students? Is it faculty? Are there wider stakeholders who need to be included? And how do we judge how effective it is? Quite often, and I know it's true in my institution, we get so caught up in the day-to-day experience that we sometimes forget to stop and take stock to think, how effective is what we're doing? How effective is the curriculum that we're delivering? And that's where quality assurance comes into it. That's where it's a really important component. Could I have the next slide, please? So this is a little summary of the curriculum and its components. And learning objectives are really important. And of course, we have those at whole programme level. We have the whole programme objectives, but we also tend to express objectives at modular or subject level. And certainly in our institution, we think of it at year level. Our curriculum's 5 years long. So it's really important to think of the staged process, the journey of students through it, and how that journey builds, and the objectives at the end of each year, to make sure that we're reaching the level we need to at the point of graduation. It's really important to think about a learning and teaching strategy. How are we going to deliver the curriculum for best effect, to make sure that we know that graduates are not just learning about content, but they're learning how to learn as well. The content is important, and it's often quite contested. When I did curriculum development work in Leeds a few years ago, we were looking very much around the fundamental science and clinical science content. And I remember very well having a room full of different specialists, gastrointestinal specialists, cardiovascular physicians, audiologists, ophthalmologists, and each of them was very passionate about what they felt needed to be in the curriculum. And of course, if we covered everything each of them wanted to do, we'd have students who would need 10 or 20 years to graduate, not just 5. So we have to really get our stakeholders to think about what's the core curriculum, what do we really need, and what can we expect students to pick up when they graduate in postgraduate training. Learning opportunities are really important, whether that's within the campus or in our clinical placements in our hospitals, primary care settings. And I'll say a bit more about that as we go through. And another vital important aspect of the curriculum is the assessment processes. So our assessment processes and the feedback we give to students, which is about helping to make them better learners, is very important that it's joined together, that it's all aligned together. Could I have the next slide, please? Now, when I trained, and admittedly that was a few years ago, I trained in a curriculum that was very traditional. It was a 5-year curriculum. We had 2 preclinical years, which were very discipline, science subject based. And then we had the clinical years later. So I didn't have any patient contact until year 3. And a curriculum that's designed at that, there's certain assumptions underlying it. There's an approach to knowledge which highlights knowledge as quite factual information, which we need to fill students with. So when it's very subject and discipline centred, students tend to look at the disciplines in isolation, and there's some disadvantages to that, which I'll go on to consider. That approach to curriculum also makes assumptions around the relationships between teachers and students. So it positions teachers as the experts who have the expert knowledge, who are imparting that to the students. And there's an assumption that they can fill the students, the empty vessels, with all of this knowledge. And that we know from modern learning theory that's perhaps too simplistic. So there may be some advantages to a traditional approach, but I'm going to argue that there's also a number of disadvantages as well. Can I have the next slide, please? This is the curriculum which I studied in 1985. Now you can see the single disciplines, you can see anatomy, physiology, biochemistry, pharmacology. So I worked very hard at these individual subject disciplines. A lot of it was lecture based, so we had the teacher as expert and we as students, the empty vessels needing filling. And I found that there was such a lot of knowledge and information, but it was quite difficult to select what was most important and actually how did this relate to patients. Could I have the next slide, please? This slide is a little cartoon, I think, which sums up quite nicely the kind of educational experience I had at university when I was training. This is a little caricature of our anatomy lecturer, Professor Young. I'm very ashamed to say that we called him Fuzzy because of his facial hair, and you'll see that on this slide. And during these anatomy lectures, Professor Young stood with his back to us as students. He had lots of complex diagrams, lots of words he wrote on the board, and he talked and he scribbled on the board, and we sat in rows behind him as students and scribbled all down madly to make sure we got every word. And afterwards, I would often feel a little bit baffled. Could I have the next slide, please? So I would come out of the lecture and think the lateral geniculate body of the thalamus, the tila choroida, the posterior choroidal branch of the posterior cerebral artery. Do I need to know this? How am I going to learn it? Am I just going to try and memorize everything and then write it all to try and pass the exam? And most importantly, it's actually going to be useful to me after I graduate. Now you'll see in the picture, there's a couple of trainee dentists in this picture. And this is where I explain to you that I am trained as a dentist, not as a medic. But in the training I had in this traditional curricula, we shared a lot of training with the medical students as well. We shared many of the same lectures and classes as well. So this approach to the preclinical knowledge, all of these isolated science subjects often left me baffled. Could I have the next slide, please? So the disadvantage to a traditional approach is that we learn facts in isolation. So we learn biochemistry in a lecture room. And then when we see a patient, it's actually very difficult to relate it to the patient. We learn pharmacology, lots of lists of drugs, lots of drug actions and reactions. And then when I came to prescribe for a patient, joining the two was very difficult. And that's because we now recognise that that type of knowledge is decontextualised. It's detached from the setting in which we want to apply it. So that's quite nicely summed up by Rager and Norman. The ability to retrieve information from memory depends on the similarity between the context and conditions in which it was originally learned to the context in which the learning is to be applied again. And when we think of learning in context, there's some very nice work by Levin Wenger which explains about situated learning, that all of the learning we do is actually closely linked to the context in which we situated at the time. So if we can teach students as close to that situation as possible, they can then apply the knowledge more effectively to patients. Could I have the next slide, please? So in contemporary curricula, we make the attempt to merge disciplines, interdisciplinary and transdisciplinary. And in Leeds and many medical schools throughout the world, we take a thematic body systems approach. So when we first introduce students to the cardiovascular system, for example, we teach them about the anatomy and the physiology of the heart, but we also teach students about the common conditions which cause heart disease. So some of the signs and symptoms which patients have. And that has two purposes. It really excites students about learning about it, but when they meet a patient, they can relate that anatomy and physiology to the patient's signs and symptoms they see. And we also, right from the beginning of the curriculum, give students patient contact. So they'll learn about a body system, they have some experience in primary care or a hospital, and when they meet the patient with that condition, they start to be able to fit everything together. So we try for this horizontal integration across the year, but vertical integration throughout the year as well. And that allows this accumulation and building on knowledge. And Vygotsky calls this scaffolding knowledge. So we recognise as well that knowledge accumulates rapidly. So when we take students in the first year of a medical programme, by the time they graduate, much of what we've taught them may have become outdated. So what we've got to think about is how do we build into our learning processes the ability for students to become lifelong learners, so that when they graduate, They can keep up to date with what is outdated, but they can actually learn themselves. They appreciate evidence-based practice. They can read journals and check sources to get up to date. So the curriculum is not just about the content, it's about the process of helping people to learn. And when you then think of the assumptions underpinning this form of curriculum, you can see it depends on a different model. We see students very much as partners in the learning process, so they have a lot of ownership of perhaps peer learning, presenting findings from research projects to other students. It's very interactive. Have the next slide, please. And this is just a little extract from our medical curriculum in 2015. And that's just to illustrate there's body systems, integrating the systems. There's clinical placement where students can see patients in practice. And it's linked to not just lectures, but lots of opportunities for seminars as well, for project work, for self-directed learning, where students take responsibility for their own learning. Could I have the next slide, please? So when we come to quality assurance, so what I've done so far is giving you my view of how I see the curriculum, and that's based on the work that I've done in the curriculum, work with other medical schools, the research and the reading that I've done. And one of the things that's become very clear to me in carrying out curriculum development work is that we need to think not just of the curriculum itself, but all of those wider structures in which it sits. So I've made, looking at this diagram in the right-hand top quadrant, I've made reference to students as partners, but who are the other stakeholders as well? So we may have regulators who are stakeholders. We need to think about patients and the community as well. And in our curriculum, we involve patients in actual delivery of the curriculum from early on. We involve them in some of the assessment as well. We have patient-written OSCE stations around communication. Many medical schools are not at that stage, but they're still very responsive to the patient needs of the local community. So underpinning that is pedagogical approaches. So how do we keep up to date with learning and teaching to make sure we're helping our students learn as effectively as possible? And what does that mean for our faculty? I've mentioned the educational environment, and that's important both within a campus setting, within the medical school itself, but also within our clinical placement. And all of that exists within much wider institutional structures and relationships. And I'll come and say a little bit more about those when we come to the next slide, please. So this, I've just extended the diagram to put some bullet points of factors that you might consider within each of these areas. So we've mentioned students and staff, patients and the community. Funders are important as well. If you have funders who are funding the medical school, who are funding the students' tuition, they want to know that they're getting some value for money. They want to know that their money is being invested in the right way. When we think about our learning and teaching approaches, we need to think about how we align our faculty development to that. So we need our faculty, and that's faculty both within the medical school, but also our more distributed faculty who supervise students in hospitals and community settings. And so within those settings, how do we best use the resources we have? We don't always have, none of us have endless amounts of money to have the best rooms or the best IT infrastructure, but how do we make the best of what we have? And how do we help students to learn within a clinical placement environment? How do we help them to take responsibility for learning from patients, from other doctors, from the healthcare team? But how do we best support the healthcare team to support them? So I've mentioned the wider institutional structures and relationships. So when I've done curriculum development work in the UK, we work closely with the General Medical Council, who are our regulator, but we also work very closely with the university. My medical school sits within a wider university, as do many. The wider university have a view on quality assurance and what we should be doing, so they need to be kept on side as well. And we need really good leadership and administration in our wider structures to support the way that we deliver the curriculum. And we need to keep communicating well with them so that we can demand from them the kind of support that we need, but also work with them to show how we're being effective in the work that we do. Could I have the next slide, please? So this brings us on to the quality assurance of the curriculum. And I'm sure all of you will have had some involvement in this area. Many of you may have had responsibility for quality assurance curriculum. And there's certain principles that this is based on. So we need to think about the kind of understandings of fundamental principles and best practice. And I'm sure all of you have a similar experience to me. Sometimes I'm so busy with the day job, with making sure I'm doing my teaching, with managing and supporting staff, carrying out responsibilities, that thinking about keeping up to date is an extra step. Carrying out that sort of keeping up to date can be challenging. But it's essential really, because we have to be very thoughtful about the way that we design programs and how are we monitoring and enhancing our programs. And I'll talk about some of the evidence for that shortly. Now, there's a number of different national and international standards which help provide a really good guide for medical education program and development. So within the UK, I've mentioned the General Medical Council. We have what's called outcomes for graduates, and they provide a guide for us. They provide standards we have to meet. There are similar models in Holland with the Dutch doctor, but the World Federation for Medical Education have some very good global standards which can be applied in different ways. Within Iran, I know that your Ministry of Health and Education have a view on your medical schools and how they are regulated. And I'm sure you may have some familiarity with the World Federation for Medical Education standards. The important thing with all of it is how it is tailored to the local context. So I did curriculum development work in Georgia and Azerbaijan, within Ukraine. And what was important was thinking about, it's not a question of taking a model from Europe and saying this will be the same curriculum which is appropriate here. We have to think about the curriculum in the context of that country, in the context of the health needs of the population, and in the context of the health service delivery. Could I have the next slide, please? So this is just to give you a snapshot of the WFME standards. So the standards which apply to undergraduate basic medical education, also standards for postgraduate education, and for continuing professional development. So when you look at the table and you look at the rows in the table, you can pick up those factors which I was referring to earlier in terms of the whole curriculum and the curriculum in context. So I'm just going to go on next to talk a little bit about the use of standards for quality assurance. Could I have the next slide, please? So many medical schools use the WFME standards for self-evaluation. So they provide a tool or a framework against which authorities and institutions can measure themselves. So they look at their own curriculum and the structures, and they use the WFME standards as a tool to measure up against it. Many medical schools, including some of the schools in Georgia with whom I've worked, have used the standards for external evaluation. So they have appointed a panel of medical educational experts to act as a panel to look and evaluate their curriculum against the standards and to take advice from them. And for many medical schools, what works is a combination of, first of all, conducting their own self-evaluation to see where they think they are at in meeting the standards, and also using an external panel to give them some feedback on how they might enhance the curriculum. And I think even if you have got a really good contemporary curriculum, because these standards move on over time, it's always worth carrying out that self-evaluation work. And certainly when we've carried that out in my medical school, a real benefit of it has been that when you ask your wider faculty to consider the curriculum and the strengths and weaknesses, and you really get people to engage with it, then it's a way of actually updating them in what's happening and also getting people very engaged, perhaps on faculty development training. So many medical schools use the WEME standards for approval and accreditation. And in some countries, the Ministry of Health has actually asked all of the medical schools to seek approval and accreditation against the standards as a way of quality assuring the medical graduates which they are producing throughout the country. Can I have the next slide, please? So this is really just to remind you of these different wider areas in which the curriculum sits in context, and you can see from the way that I've built that up how it relates to the standards. Thank you. Next slide, please. So what kind of evidence will be used in quality assurance? And I'm sure each of you in your own medical school use this type of evidence. One of the things at the heart of it is your institutional mission and outcomes. What outcomes do you want to achieve? And that's very much linked to the values. You know, what are the values which are really important to you? What kind of graduates do you want to produce? How do you see patient-centered care, for example? How do you see your curriculum as really addressing your healthcare needs? It's useful, as I've said, as a standard to look at your educational programme. Is the programme aligned to addressing your healthcare needs? Are the changes that need to happen? Assessment processes. So are you testing the right things in the right way? So are you, when you are actually testing students' knowledge, are you using a knowledge test? But when you need to look at competence, are you using a test which looks at how students actually treat a patient, carry out a history examination, diagnosis? So you're aligning your assessment strategy to the programme and outcomes. Staff recruitment and training is important. And one of the things that we found when in Leeds, when we carried out curriculum development work, we found there was a great need for staff training, but also we realised because we were taking some things out of the curriculum and strengthening and emphasising different areas, it had implications for the kind of staff we need. And we actually involved a lot more clinical staff in delivery of the foundational science because they could link it to patient needs in a more effective way. I think the training is really important for all of us, and our recent experience, and I'm sure yours is similar, with COVID, we had to have some very rapid staff training in order to deliver much more of the curriculum online. And it was very interesting that when the need was there, that training was carried out much more quickly and effectively than it would be under other circumstances. And that has implications for educational resources. Some medical schools are very fortunate in having very high quality resources, a lot of financial investment. But I think what's really important, it's the ideas, it's having the right understanding and knowledge, having people enthusiastic in how you deliver that. And then with much lower level of resources, you can still do a fantastic job. It is important to be able to monitor and evaluate your own programme as well as having any external evaluation. And you might do that from student feedback, faculty feedback, but particularly as well, how do you know what kind of graduates you're producing? How do you know, are they effective doctors? Do you get feedback from your hospitals, from your primary care centres to tell you that? What other evidence can you use? And what evidence can you get that your governance and administration is working well? Do you have governance and administration which actually picks out where there are issues, but supports the medical school to overcome those issues and provides good leadership and provides the kind of resources that you need? And what about your interaction with your wider partners? We have a lot of meetings with our clinical placement partners in hospitals and primary care settings, and those are vitally important so that we understand the pressures all of us are under, and we support each other to train the students and meet healthcare needs, meet our patient needs. Could I have the next slide, please? So if you are thinking about reviewing your curriculum or thinking about quality assurance, this is just a few steps to think about and conducting a needs analysis. And these are the kind of things I've referred to. Are you addressing your population needs? Do you have overarching programme outcomes? Is the curriculum appropriate? Are you spiralling content so that you expect more and more from your students and you're scaffolding their knowledge and building throughout? Are your faculty trained to deliver and up to date? And as I said, I know this can be a challenge, and we've had this very recent challenge of having to train faculty to deliver much more online teaching. And are you assessing appropriately at different stages? How do you know you're graduating competent doctors? So you might think about what are the standards which might be useful for quality assurance of your curriculum, and that's going to depend on your own country and your own medical school context. Next slide, please. So in summary, I hope I've given you some food for thought around contemporary approaches to curriculum and how we view the curriculum in this much wider context, and how we think about governance and institutional relationships, students and other wider stakeholders, and how we might think about ensuring we have high quality pedagogy. And for us, integration is a key goal. I believe in Iran that you have a 7-year programme where students do 2 foundational science years and then 5 years in the medical school. So it's the medical school years. Are you integrating horizontally and vertically? And is your faculty training aligned to any curriculum development work you're doing? So I hope that's given you a few thoughts. And I'm really looking forward to answering your questions and having a discussion with you on any issues you'd like to consider. So the last slide just has some reference sources which might be helpful for you. And obviously you can have a copy of the slides after the event. So thank you very much for listening. I appreciate you coming to the webinar on a Saturday morning, and I'm looking forward to discussion now.
Anne-Marie, I noticed that there is a question in the Q&A section.
Yeah.
From Amir Ahmad, and the question is, can minimum standard for quality assurance be set internationally, which should be followed by every country? What can be role of the WHO?
Right. this question around can a minimum standard for QA be set internationally, that's very much the work which the World Federation of Medical Education have tried to do. This has been it's been a very long process. The WFME have taken a number of years in doing that, and they've involved partners internationally. So it has been a truly international effort. And what the WFME are very keen to emphasise is the standards are very much a guideline, and it's very much about interpretation within the local context. So I think there should be, in answer to your question, I think there should be a core minimum, but it's not a cut and dried question in as much as this interpretation. In terms of the WHO, I would say the WHO we look to for advice on the healthcare needs globally, which we need to be addressing. So I'm very well aware of the healthcare needs within the UK. However, in the last few months with COVID, that's changed very rapidly, as we know. So I think we would look to the WHO as expert partners in having a stake in the curriculum and helping inform us of the global issues we need to address. All of our students are global doctors as well as local doctors, and many of them will travel throughout the world, but we know our patient populations are very mobile. So I think the consideration of WHO is a really important one. Thank you for the question.
Are there any further questions? Please feel free to use the Q&A box at the top of your screen.
And if the person who asked the question wants to give me a response, I'm very happy for you just to respond as well.
So Alison and this is Shabi Zaidi from London. I can relate to your cartoon very well, because when I was a student way back some 50 years ago, my teachers used to be exactly like that. Yeah. They would never face the students, they would face the blackboard. And would you believe it, my teacher was Professor R.J. Last, the famous Professor Last. He was a superb teacher, but exactly what you described. He would stand towards the blackboard and draw beautiful pictures and all this. So this is the question that I'd like to put to all educators. Why is it that it took so long for people to realize that the curriculum, the syllabus was overburdened with all the details like you mentioned? I remember reading Gray's Anatomy, literally from page to page, which was ridiculous. It's like trying to learn a language like English from Encyclopedia Britannica or something. So the question is, why did it take so long for Flexner curriculum, Flexner's thing, to continue and be replaced in 1950s or something? Why is it that people did not challenge the overburdening of course and syllabus many, many years ago?
Well, I would say it's a very, very good question, thank you. And my view on that is, I think it was partly aligned to the hierarchical structures. Mm-hmm. So in the UK, as I was growing up, if you became a university lecturer, which was obviously a very high status position, or university professor, it was a very high status position. You wanted to maintain that position, and it was very comfortable to do what you had always done. So because people were positioned as experts, it was quite difficult for younger faculty coming through to try and introduce new ideas in learning and teaching. And in fact, I think in medical education has been quite slow to respond in many ways. So I think if we look at wider higher education, but perhaps even more important, school education was much more responsive to recognising that too much knowledge and information overload was not effective, and it's very much about learning to learn and developing skills and being able to tease out what are the really important things. But I think in universities there was quite a resistance to it, because certain people had positions in which they were very comfortable, and also I think a lot of people genuinely believed that was how they'd been trained, so it must be the right way to be trained. And for most of us, it would be about questioning our elders and betters to say that you may have been trained that way, but perhaps it wasn't so effective. So I think that's partly what took a long time. And I think in medical education, the work of Ron Hardin was very pivotal in this as well. And there was the Edinburgh Declaration. The Edinburgh Declaration looked at the medical curriculum in the UK, partly looking at the Flexner report as well. And through the Edinburgh Declaration, the medical education community got together to start these discussions about what medical education should look like and how it should move on. So I've got a question. I can see a question from Trudy Roberts, which says, what do you think the curriculum will look like in 30 years' time? And that's such a difficult thing to answer. And I think if I asked everyone here, I imagine we're all now responding to COVID. The medical education curriculum has been much more driven by online resources, remote teaching. We are very much engaged at the moment in trying to develop some really good technology-enhanced learning resources, which gives students an authentic learning experience, an authentic patient-facing learning experience without actually facing patients. So it gives them a very good simulation experience so that we can make sure when they are in clinical placement, that time's being used as effectively as possible, because at the moment the pressures of COVID is such that we are having to try and we have students in placement in hospitals and primary care, but we have to make best use, effective use of that. So I think that online remote simulation teaching, and we've got some great 3D resources that accompany that. That's going to be very important. I think it will be much more, we talk about patient partnership, but I think the patient partnership and the patient views on what's needed, patient decision making will be really important as well. And I think it'll be much more personalised. So we have DNA sequencing. In theory, if I need the same drug as Alison, if you sequence my DNA and you sequence Alison's, you can actually tailor that drug to me specifically to personalise it and tailor Alison's to hers. So in principle, some of that technology exists now, and I think that will become much more important, that much more personalised medicine. But I would be very interested in other people's views on that as well. And there was another question, with curriculum development priorities, what should be the first consideration of needs? Now, I think the first consideration of needs is partly using the evidence that you have already. So what evidence have you got at the moment for how the curriculum is working? What evidence have you got around your graduate outcomes, how your graduates are doing? What feedback have you got from students? What feedback have you got from faculty and other partners? That will start to give you an idea of where you are at that point in time. One of the things that we did when we were thinking about curriculum development in Leeds, we looked across other models through internationally, and we did a lot of that through reading journal articles, speaking to people, and making some comparisons with what was good about those curricula and where we perhaps had gaps to fill. So I'd say that was the first part. And if you're using a set of standards, the WEME standards, to do that, that can be helpful. And there are some documents. So when I worked in Eastern Europe with medical schools there, we used a needs analysis pro forma, which asked these questions about what evidence do you have for things working effectively, and we use that needs analysis as the first point. But it's very much a collaborative effort. So one of the things I would say that's really important to think about, if you are going to change the way people do things when you develop your curriculum, you need to take them as partners with you. So you need to communicate really well with all of your wider stakeholders and what you're planning to do, and involve them as partners in the process. And for us, the involvement of students is vital to that. Our students in the UK have a very strong voice on the curriculum and what they think it should look like. They're not always right, but we do involve them carefully, and we involve our patient and carer community as well. So I'll be very interested if other people have any experience to share in that, or any ideas about the curriculum in 30 years' time.
Anne-Marie, there are a couple more questions too. Would you like me to pose those to you?
Please, Alison, I perhaps have missed them, yes?
Yeah, that's okay. There's a very nice question from Hussam Al-Zuwaini here, who compliments your presentation and says, is there any solid evidence which type of curriculum is better? Is there evidence that the integrated curriculum is superior to the classic one, and why?
I think that's such a good question, and it's making me smile, because this is a task I set my students, for them to try and find the evidence. And I would say some of the evidence is circumstantial, probably. I think what is important about it is looking at the graduate outcomes. And what's most important in the curriculum is the model is important, and I think a contemporary curriculum saves a lot of time. So I've mentioned the fact that as a student I was stuffed with all this factual knowledge, a lot of which, not most, but a lot of which wasn't any use to me in graduation. So we know with a contemporary curriculum, we have evidence-based for learning and teaching strategies that work effectively. Those are the ones that are interactive and involve students. We have an evidence base for student achievement. So if I give you the example of my own medical school, and there are other examples like this in the literature, I have quite solid evidence that student achievement improved once we made the curriculum more integrated, and we have comparable exam results for that. We also have evidence that the student satisfaction improved, and we have evidence, some of which is anecdotal from our partners in hospitals and primary care, that our students were more ready. And we have a survey which is carried out each year by the General Medical School Council, and that actually showed us our graduates were more ready for practice after the integrated curriculum was introduced. Having said all that, irrespective of the type of curriculum or the tools you use, it's how effectively you use them. So it's also about your faculty development training, the belief in what you're doing and the enthusiasm of faculty to deliver it. So you can't take any of those things in isolation. So it is quite difficult to just compare one model to another in isolation, because it's within this much wider context of institutional structures, healthcare needs and so on. But a really good question, thank you.
Thank you, Anne-Marie. I'd like to invite Amir Ahmad to come to the microphone, please. Amir's question is around the context in Iran and some of the constraints within Iran. And I think it'd be nice to hear from Amir himself what those are.
Yeah, thank you.
Okay, thank you. Very nice presentation, really impressed. But my question, as you might be noting, that mostly they revolve around the disparity in the standards in different countries. Basically, we are facing a lot of problems in the third world countries, like the developing countries like Pakistan and other countries, where the political interference becomes very much. And this is the education, medical education is a field which should have some uniformity. Most of we people are busy in our business, in our the heavy teaching and all these things. But the problem is we can't spare much of the time for coming forward and for making some basic principles which should be followed by all the schools, basically. So uniformity is lacking, and the political interference is one of the problem. So although this is very difficult to ask some country to abide by the set principles, but there should be some mechanism that the minimum standard should be compulsory for every country. Like the WHO, I already asked the question, can play a very good role in that, so that there should be some pressure from the international agencies, and although they are doing a very good job already, they are not sitting idle, but we have to come forward a little bit more. Thank you.
Oh, thank you for that. I think you bring up some very, very tricky issues there, very, very difficult issues. And I appreciate that politics, the political context, does not always support the kind of work that we would like to do. It isn't always conducive to reaching the kind of ideals which we hold. And I don't think there's any simple solution. So I can just share with you some of my thoughts on that. And one of my thoughts would be, the more that you can involve the people in positions of power, the better. So I mentioned the work that we did in Georgia on curriculum development, and our colleagues in Georgia very much needed the politicians who were to actually engage with it as well, to support them. And so on the local basis, they worked very hard to actually make contact with the Ministry of Health and Ministry of Education in order that we could, as a group, you know, my UK colleagues who were working with colleagues in Georgia, to meet the Ministry of Health as a group to explain to them our aims, to try and get their ear. And that was very helpful to do that. But it won't work like that in every country. I think communication is key, and if you can engage some champions for you, some people who do have the ear of politicians to get your support, then that would be very helpful. I think the idea of having a minimum standard internationally is an excellent ideal, but it's very difficult to impose that, as you know. And the World Health Organization, or WFME, they can express a justification for it. They can try and work with political leaders to see why these minimum standards are important and the benefits it will bring, but they don't have the power to actually impose it. But I think having conversations with the WFME may be one way forward, and if they can work with the WHO as well and other international organisations, perhaps then we can start to do that. We can start to have the conversations around, can we have some minimum standard internationally? Who would actually be able to implement that? What kind of repercussions would there be if countries don't meet the standard? But they're massive issues to deal with, but it doesn't mean to say we shouldn't have conversations about it, and we shouldn't have good intentions to try and work with each other to support it. But so I think that's on the large scale political basis. But I think then as a medical education community, we actually have the opportunities to support each other as well, and to share experience in how we overcome problems. So many countries will have a political context which is not conducive to them producing the best doctors or best health professionals. But if we work as a medical education community to share experience with each other in what problem solving measures have worked, then we can work together on that. And I think the medical education community is full of people with a lot of goodwill, experience and expertise who want to share that with each other for the best reasons. And often that can overcome those sort of political barriers, and it can break down walls. So maybe that might be one approach. If you have any other ideas, I'll be very happy to hear them.
Anne-Marie, we have just a few minutes left now, and there are a couple of last questions about the place of particular components in the medical education curriculum. So the first one was from Mubashir Iftikhar. Is data science included in our curriculum, and at what stage of training?
Yeah, we do include it in our curriculum in Leeds, in terms of our students can do training in research skills. So throughout the curriculum, they do training in research, and part of that is looking at data science, and part of it is looking at big data, looking at epidemiology. I have to say, not all of the students love it. And as someone who carries out qualitative research, who's very interested in the qualitative experiences of patients as well as the data, sometimes I think we don't get the balance right. But I think it should be included from the point of view when our students graduate as doctors. I've mentioned that we want to train lifelong learners, and for them to be good doctors, they have to be able to read journal articles, and part of that is understanding data which is being produced in the articles, understanding quantitative research evidence and so on. So if I'm understanding your question right, I think data science should be a part of it, but it's quite difficult to say how much and when. I think as part of research skills training is very useful, and also part of public health and epidemiology, of course. And if there's anything that's made us appreciate how much international health data is important, then COVID's brought that home to us, I think.
Yes, I would agree, Anne-Marie. I'm finding students are much more interested in data at the moment. Thank you. And yes, so at Leeds, we have research as a strand that goes through the whole of our curriculum. And I think public health and epidemiology is a topic that's repeated throughout the 5 years. Am I correct, Anne-Marie?
Yeah, that's correct. Yeah.
And so our final question is from Madad Ali, who asks, how do you start teaching advanced clinical science to a fresh graduate without giving them preliminary knowledge of body systems?
Right, well, all of our students who come into university have to have done A-levels in science, so that the A-levels are, our students stay in school until they are 18. So the A-levels are already at a good level of science knowledge, and they come in with that as a precursor to it. But even within school, when they're learning the science, they do have some training already in relating it to body systems, because it just motivates them better to do it. So when we start them in teaching clinical sciences, it's not advanced clinical sciences initially, it's fundamental clinical sciences. They do have some grounding, but we cover it very rapidly as well. So the students realise very early on they need to work hard at it, but because it's engaging for them, and because right from the time they start medical school, we're already relating it to patients, and they see patients fairly soon after they start. Even though they have a lot of hard work to do, they become very motivated by it. And I think we shouldn't underestimate them either. But part of it is working with students, and you might do. We do quite early on as well, we do some initial testing on their science knowledge, so that we can see the students are following the curriculum, and or if the curriculum is being delivered too fast for them, or we're losing students on the way through. So we do quite a lot of formative assessment. So the formative assessment, where are you up to, where's your strengths and weaknesses, and how can we to support you? And that formative assessment is useful for individual students in knowing their strengths and weaknesses, but it's very useful for us as a medical school to make sure that the students are understanding what we're teaching and the delivery is being effective. So I would say don't underestimate students either, and many of them will hear about science topics in the news. They'll start to read journals because they're interested in the topics. So I hope that answers your question.
Thank you very much, Anne-Marie. I think we may be out of time. There's a couple of last questions that perhaps you could type an answer into at the end of this session, but I think we're now at 12:03, so perhaps it's time to bring this to a close.
Yep, that's lovely. I'll have a look at those questions.
Thank you so much. Maybe I'll get Dr. Shabizadi, if you're able to say a few words.
Sure. Well, I have no words to thank you, Anne-Marie. As expected, of course, seasoned teacher, all experience from different countries, different regions. We are grateful to you for giving such a wonderful talk. Of course, it'll be uploaded, your webinar will be uploaded on the webpage of Sadiq International Virtual University for those who missed it, and they will benefit. Thank you, Alison, for holding it and holding the fort, so to say, because I couldn't have done it. It's very difficult to moderate with wonderful speakers from all over the world, scholars trying to ask several questions. So no words to thank you both, most grateful. And we'll continue the series. There might be a slight change. The next workshop, Shifa is going to announce that. I just wanted to thank you both and thank all the participants for giving so much time to attend this webinar with the only purpose of propagating education. Thank you, and over to Shifa.
Yes, thank you so much. This is such an informative webinar, and thank you so much for answering all of the questions from the audience. Before we go, I would just like to announce our next activity, which will be an e-learning workshop by Mr. Hasnan Zafar Baloch on the 21st of November. So please look out for that, for details on that. And we hope to see you then. Thank you so much.
It's been a pleasure. Thank you for your kind words.
Thank you, and bye.
Bye.